Okay, I'm delighted to be here today with Dave Baker to talk about all things painkillers and medication, analgesia. And the first question is always the most straightforward, or at least it should be, which is, can you introduce yourself for the listeners and tell them a little bit about your story so far?
Okay, I'm Dave Baker. I work partly still in the NHS as an ESP in North East London at part of the Homerton Hospital, where I work in part of the time in chronic pain clinics, other part of the time general ESP list, ultrasound injections. I also work in private practice 3 days a week in and around central London, and do lots of work with a whole range of variety of patients. Injections and prescribing is part of what I do, but by no means all of what I do.
Yeah, so you're fairly renowned within the physio CPD sphere for running pharmacology style courses even before we could independently prescribe. And so what led to an interest in medication and that direction, as well as alongside you being musculoskeletal?
Yeah, I think the time that I really became interested in it, I was working in a split post, and this is going back probably about 15 years, and I was working in a split post rotation, working partly in A&E, in an injuries unit, and the other half of my week I was working in a chronic pain service. And one of the things that always really struck me was that when patients came into A&E, one of the first questions that they would be asked about is what analgesics had they taken. If they hadn't taken anything, they'd be given some, put over in the corner until the analgesics started to work. And so really having half a mind on what painkillers the patient was taking was all part of your sort of clinical reasoning and patient management and assessment process. I then walked round to the physio department, and particularly in the chronic pain service, a lot of the time, if you would stop and ask one of the physios what painkillers were their patients taking, oftentimes they wouldn't be able to tell you. If they could, they certainly wouldn't most of the time know the doses or whether or not the patient was actually taking them. And it just made me think, as physiotherapists, we spend most of our time talking to patients about pain and dealing with patients that are in pain. Surely we should know a little bit more about pain medication and all matters to do with sort of medicines management. And that, I think, was my original, what triggered my interest. I think I was always slightly disappointed when I think back to my sort of original physio training. When I first qualified as a physio, I think I was always slightly disappointed at how little physios sort of knew about medications as well. I was surprised how little there was in our training, or if there was in our training, how much of it actually carried through into our clinical practice. So I think the thoughts were already there, and then it was really triggered by this situation. And what I then became really passionate about, because this was before physios training as prescribers was even an option, that physios should be taking more of a role in asking them and advising patients about the medications that they're already taking them, and telling them or advising them how to take them most effectively. So that was something that I originally became interested in, and the whole physio prescribing thing came along after that.
Yeah, I think I've thought about this, and most thought about it around the time in which I did my injection course and had to start re-engaging with the biochemistry a little more than I had done previously. And I wondered if the cohort of physiotherapists will sometimes they'll reject pharmacy and medicine as a reason of going into a more anatomy and physiology based profession as being physio. They're kind of trying to turn their back on the chemistry a little, perhaps. And then I wonder if that then is deep rooted, and they therefore will try and reject some of that and never really learn about the pharmacodynamics and stuff that we're probably going to go into. I sort of wonder if that's part of it, but it's certainly we need to book that trend, because if we're going to be truly holistic practitioners and we care about the multi-dimensional aspects around people, then what they take chemically is pretty relevant to a lot of things, and especially as we're diverting into more ESP roles such as yours, then I think it's super important. Can we talk a little bit about how the historic role of physios when it comes to analgesia and how that's changed over time that brings us to the present?
Yeah, I think if you go back nearly 20 years now, when I first was training and qualified, I think physiotherapists generally, their understanding and their perception was that their role was completely away from analgesics and medications, and certainly, you know, I can remember sort of being told by my sort of seniors and supervisors, you know, that you just simply didn't talk to, it was not part of our role, it was not part of our scope of practice, and that, you know, we shouldn't really sort of like be entering into those conversations with patients at all. So I think that was kind of the main sort of accepted position with regard to physiotherapists. I think a lot has changed over the years, particularly, I guess, as you mentioned, with physios injecting and physios working in a much broader range of roles. My first role that I had to do with medications was in A&E, and I was allowed to supply and administer medications under PGD, which is obviously how a lot of physios get their first contact, if you like, with using medications. And I think this is, and working in roles such as community settings, chronic pain services, I think increasingly now physios have found that, you know, they come into contact with patients that, you know, where their pain is being poorly controlled. And I think the profile on this issue has just been raised over the years, that people are a lot more conscious of it and are a lot more conscious of the potential issues. That said, I do go to a lot of physio departments where I do, you know, my teaching about physios advising patients about the analgesics, and there's still a lot of physios who I would say know very, very little, or have paid very, very little interest in analgesics and painkillers, and that's fine. And you know, that's a decision. You know, if you decide that that's where you prefer to be, then you know that's fine. That's a decision. But I think increasingly people see the value of being able to have these conversations and being able to discuss these areas with their patients as well.
And so over the course of time, we've gone from this idea of rejecting it to this idea of now embracing it, and it is a fashionable sort of direction of travel for the profession, particularly at the top of our licence, and there has been a real culture shift in that. When we think about the positive angle towards physios rejecting it, was that there was then a more comfortable sort of niche scope of practice in which it was just, you want to talk about your tablets, you talk to your doctor or a pharmacist. It's just the obvious sort of mantra that people would have. There is some security to that though, isn't there, in that people do feel that there is they're in a safe bubble in which they just reject that side of things that they don't feel qualified to. And I understand that the CSP's guidance on this was always talk about what you feel was within your individual scope of practice and knowledge. And I think I've even heard you lecture in that, saying this is where the land lies. So can you put people's mind at rest as to what they're allowed to do, as well as what they have done historically?
Yeah, I think one of the something that's really useful for physios to perhaps have a look at is the CSP briefing paper PD019, which actually has section 3.
We can link to the specifics, yeah, no problem.
Gives a lot more clarity now around what the role of a physio can potentially be. And I think, as you mentioned, you know, the bottom line always has to be where the patient feels confident and competent with their knowledge in that particular area, with the particular medications that they're feeling that they wish to discuss with the patient in their area of specialty. And it's about talking about medications that the patient is already taking, such as over-the-counter medications, and also having a discussion again where the physio is confident that they have the appropriate level of knowledge, competency to discuss with the patient about medications that they may wish to consider taking. And I think that is the key thing. We're not for one moment suggesting that anybody should talk outside of an area that they feel confident in. It's more people potentially seeing this as an opportunity and developing their skills and developing their knowledge so that they can incorporate this in the overall management and treatment of their patients. I think a lot of the time, you mentioned about patients potentially discussing these matters with their GP and community pharmacists. I think a lot of the time when you speak to patients, and this is certainly something that I've noticed, and when I talk to other physio prescribers within the chronic pain clinic, is that they have had very, very little opportunity to discuss their pain control medication and been given actually very little guidance, I would say sometimes very poor guidance about their use of medications. And one of the things that I think that physios are potentially very good at in their sort of core set of skills is about monitoring, reassessing whether or not the treatment is being effective, being able to interview patients and help them decide on potential sort of treatment pathways. And that's something that I think is a very strong skill amongst our profession, and I think it lends itself very well to medicines management. And this is why I've been sort of such an advocate of physios skilling up in this area, because I see it as being such a potentially useful adjunct tool in our box in terms of managing patients.
And so the "it's not my role" argument doesn't hold up, but then also the idea in which they're trying to be safe rather than sorry, that doesn't really play out in our scope of practice. There's certainly, you're not on shaky ground legally to have these discussions with patients, as long as you can prove your own individual competence and that you're working within what you perceive as being your own individual skill set. Have I got that right? Yeah,
and I think the thing is, I mean, this question sort of obviously comes up a lot, and you know, I point to a few things really. The government's briefing paper back as far as 2004 on the management of long-term conditions talked about the role of all clinicians within medicines management, and that all therapists or all healthcare professionals working directly with patients, including healthcare assistants, which is a non-degree entry profession, being involved in aiding patients with medicines management, trying to support compliance and concordance and good medicines usage. And I feel that this is something that, you know, physiotherapists are certainly very capable of taking into their skill set if they wish to. Again, as mentioned, it's very much around people feeling confident and competent of their knowledge and skills when they're discussing these medications. And the fact is, and this is something that we, you know, the vast majority of patients, and this comes out in study after study going back to the 1970s and 1980s, looking at a whole spectrum of medications that are taken in acute and long-term conditions, showing that compliance and concordance usually hovers at around about 30-40%. So in other words, around 60 to 70% of patients are not taking their medications as prescribed. This includes overdosing, underdosing, staggered overdosing, which is taking slightly too much over a prolonged period of time. So this is really an opportunity for physios to, first of all, come in and help to police what patients are doing, because what they are doing at the moment, study after study shows, is not helpful oftentimes, and is putting them at risk, particularly over usage of drugs such as non-steroidals. And also being able to guide them in terms of best practice and best use of their medications. I spend far more of my time actually reducing medications that patients are currently taking, rather than adding medications in. So much of the time people have been taking non-steroidals, such as diclofenac, been taking it for maybe 10-15 years because they believe it's disease modifying. No one's ever told them it's safe to come off it. So there are huge opportunities with us as a profession to try to facilitate and support patients to take their medications more safely and more effectively, and certainly not for one second suggesting that we would be pushing patients to be taking lots more medications. Far from it. Most of the time it's just about marshalling them and supporting them, educating them about the medications that they're already taking, and sometimes making suggestions around medications that may be useful for them to consider to take.
Yeah, and I think that's a useful angle, isn't it, as well, to just say, why not have another another string to your bow in that you're able to articulate an answer to that question. Not always the answer, it might be difficult to always marshal that, but the ability to not have to pass that book and to put the burden onto the patient to have to go and have another appointment, and the rush that we know in primary care, GP practice and things like that is such that even if there was an optimal GP to talk to these things about, who knew more than we did about it, it's still logistically difficult. So to be able to articulate that and have that back and forth with the patient is invaluable, and it further instills confidence. It's one less question that we have to hold back on.
Yeah, I think that just expanding our knowledge around this area, just with even if it's just with the over-the-counter medications, I think people, and I hear this again back all the time from people that come on my courses and things, and where I've done talks, is people say you just didn't realise how often patients were asking about medication, and they either just diverted the topic or had stock answers, go and speak to your GP, go and speak to the pharmacist, and realising that actually engaging patients around this topic, patients really do appreciate this idea of one-stop shop, that you're able to add value to what you're doing and be able to answer the questions there and then, because this idea of send them back to the GP, how many of them will actually go back to their GP who ask that question, or how many will just have unanswered questions in this area? So I think that's the thing we should consider. And
how many of those that even do get an answer that would have been in excess of the information you did give them, or more accurate by any stretch? So not in a second I'm bashing our medical colleagues, but they've got a lot on their plate, and so it might well be that us as specialist MSK clinicians might well know more in that. Even if we're non-prescribers, we might be more educated in this direction than a GP might do in specific analgesia. So it's worth bearing in mind. One thing I want to then take us to is we're going to go in, systematically through some of the types of medications that we would see a lot of in MSK. And so I want to start off with typical analgesics then. And so I want to start a little bit about what they do, their indications, the similarities and differences between the things like the typical pyramid that we see. So if we can start off with that, that'd be really helpful.
Okay, well, if we start off at what traditionally people sort of see as being the sort of bottom end of the analgesic ladders, we'll talk about paracetamol. And in terms of, I guess, just some of the key things to potentially think of, and I always, when I'm talking about medications and when I'm trying to teach about medications, on the one hand you've got the sort of like the physiology, but on the other hand it's just sort of recognising, I think, just the sort of like the main characteristics of a drug and how it works, because sometimes that can be a lot easier to sort of remember and to sort of help us think about when these drugs might be potentially useful. Paracetamol has a very complex, it does a lot of very complex things within the body, and it's actually relatively poorly understood analgesic in many ways, because it does have so many sort of complex activities within the body from a sort of pharmacodynamics and pharmacokinetics perspective.
Probably worth just elaborating what the difference is between those two things.
Okay.
Not only to refresh mine, but also for the listeners.
Okay, so when we're talking about pharmacodynamics, we're talking about what a drug does to the body, and when we're talking about pharmacokinetics, we're talking about what the body is trying to do to the drug, so how it processes the drug through the body. Okay, so if we're talking about the sort of therapeutic effect, the main therapeutic effect of paracetamol, I guess the thing to think is it works mainly centrally, so it's working within the central nervous system, and it binds onto a specific receptor, which is most commonly found on nerve cells. And this receptor that it binds onto is a receptor that is related to just about every different type of discomfort that a person can feel. So it's a receptor that's involved in coughing, itching, feeling cold, feeling uncomfortable. And it's a trigger to the receptor, TRPA1 receptor, if people wish to look into this more. And it was only actually discovered that this was what paracetamol was doing about 6 years ago. But it gives us an idea about how paracetamol potentially might work and why it is such a good sort of blanket medication for such a wide range of conditions. I always give the example of Calpol. You can give Calpol when we give to children and they've got pain, it makes them feel better. But if they've got a temperature, it helps bring their temperature down. But also, if they've lost their teddy and they're upset, you give the baby Calpol and it just seems to settle them. So paracetamol just seems to have this effect on the body because of its mechanism of action, where it just makes us feel less perturbed by our environment and just makes us feel a little bit more settled. I think this is why it's such a good co-analgesic, and hence why you see it put together with lots of other analgesics, either within the same tablet. So you think about cocodamol, codidromol, Tramadol. This is where paracetamol is being directly mixed with another medication, because it seems to have an enhancing effect on just about every other medication that we can take. So when we're thinking about paracetamol, it's a good medication for a whole wide range of mild and as an adjunct in mild to moderate pain, discomfort, and that's what it seems to be doing. And if we bear this in mind and think about how this then can be used within a whole sort of medications program for someone, that can be quite useful. The other thing to remember with paracetamol is it's in some ways it's actually a very dangerous drug, because it very, very quickly becomes toxic within the body. So if you think about paracetamol, there's only really one dosage, if you like, of paracetamol that we can take. That's sort of 2 tablets 3 to 4 times a day, 1 gram 3 to 4 times a day. That's been shown in a number of studies to be the sort of minimum therapeutic dose, or certainly around 600 to 700 milligrams 3 to 4 times a day, the minimum therapeutic dose of paracetamol that we can take. But the limit that we should take is almost exactly the same, 1 gram 4 times a day, and even very small levels above that very soon become toxic and are relatively very, very harmful for the body. If you think that more than 60 to 70% of all suicides involving medications, the primary medication is paracetamol. So it's very, very toxic, and people oftentimes, still unfortunately accidentally overdose on paracetamol. So some people suffer extreme toxicity at doses as low as 7 or 8 grams in a day, which is less or twice as much as the recommended daily dose level.
Now, is it that, so we're talking about something that's centrally acting for its mechanism of benefit. When it comes to toxicity, the mechanism's not necessarily that it overwhelms the nervous system, is it? It's
not at all.
You get then an organ rejection. So just quickly, if you touch on
okay, so the problem with paracetamol is within the liver, and essentially what happens is it's processed within the liver in the sort of 2 parts. It goes through phase 1 and phase 2 processing. The problem occurs when it's partially metabolized within the liver. It creates a very, very toxic substance which causes a huge amount of damage to the cells within the liver. So the problem when we overdose is that simply we bottleneck paracetamol coming through the liver. The enzymes in the liver can't cope. It's trying to metabolize it, so it partially metabolizes it, it can't complete the process. Suddenly we get this build-up of this very, very toxic substance, and this is why we get catastrophic liver damage when people overdose. But the thing that people are oftentimes less aware of is that paracetamol competes with enzymes for metabolism in the liver with alcohol. And unfortunately, it's very common nowadays. People obviously take paracetamol to help with hangovers, and we get a lot of people coming through the pain clinic who maybe curtail some of their other medications, but very oftentimes drink and take paracetamol at the same time. And this can cause catastrophic liver damage, particularly over a long period of time. So, and unfortunately as well, this correlates with what's known as staggered overdosing, and that's where people take slightly too much over a prolonged period of time. So say they're taking 5-6 grams of paracetamol every day on the basis that it's freely available, therefore they presume it's low risk. They see it's for mild pain. I think, well, I've got moderate pain, so if I take twice as much as it says on the packet, I should be all right. And there's, for various sociological reasons, there is a huge overlap and cross-correlation between people that staggered overdose or take slightly too much over a prolonged period of time and taking with alcohol at the same time. And so there is lots of people now starting to come through with long-term liver damage as a result of prolonged paracetamol usage coupled with alcohol, which is, I'd say, is something that is really not very much known about within the public, and certainly lots of people habitually take paracetamol before they go out drinking. I hear a lot of the time to actually help reduce the hangover the next morning, which is obviously bad news as far as your liver is concerned.
Absolutely, no, that makes sense. Now, to go just back to the therapeutic dose point, is there a threshold that we know of for most people, in which, because I know it varies, we all vary a little individually on how we metabolize medication. I'm sure we'll come to that a little more when we come to the codeines and the like. But when it comes to, if we talk about minimum effective dose, we can probably then just wrap that off really quickly on the other medications. But is there a level in which part one, where we don't necessarily have a level that's going to be meeting the effective dose? So if you take one twice a day, one 3 times a day, does that therefore make it completely bogus, and any mechanism of benefit you get therefore would be under the non-specific placebo effect type thing? Or so you said there's a narrow window. How high towards that 8 tablets a day marker is that?
So from what I've read around minimum effective dose, because we do, obviously, again, we get asked this because sometimes with our elderly patients, if they've got known to have downregulation of liver and kidney function, then sometimes they are requested to be on a restricted or reduced dose of paracetamol, and often the question is asked about, what is the minimal effective dose. I believe from what is known in the literature that probably around 500 to 600 milligrams in a single dose is probably for most people, and I'm talking obviously now for an adult, is the usually deemed to be around about the minimal effective dose level. So that would be sort of like one single tablet, and anything below that is probably going to be sort of sub-therapeutic. But
so it doesn't matter over a course of a day then, typically? I mean, we're in that situation where it's kind of one, if you take 2 at once, then that would be fine. But so that would be a dose. It wouldn't matter then. Someone takes two a day. Yeah, that's still going to be within that effective window.
Oh right, sorry. Sorry.
I meant cumulatively as well as.
Oh right, okay. So paracetamol's got a very sort of short half-life within the body. It's got a half-life of only like 1 to 2 hours, really. And this is why why for these analgesics, all of the analgesics, most of the over-the-counter analgesics have very short half-lives, hence why you have to take them sort of 3 or 4 times a day. So paracetamol will only be sort of effective for an hour or 2 after you take it, and by that time then it's then much of it has left the system, so it becomes, again, it's the levels of paracetamol within the blood would be sort of sub-therapeutic level again. This is something we talk about with patients about sort of a regular usage of analgesics, and how that this can this very same concept can be used to actually improve the effectiveness of medication. So it's concept known as steady state. So if you take, for example, paracetamol, it's got a half-life of around, say, 1-2 hours. If you're taking it at regular intervals every 4 to 6 hours, or four times a day, 4 doses taken in a day, it takes around about 2 days to reach what we call steady state within the blood, and that is the, if you like, the maximum safe dose, the maximum safe circulating dose of paracetamol that you can have, and you reach that after about sort of 5, 6, 7 regular consistent doses at the at these sort of predetermined sort of spaces for every 4 to 6 hours, with a maximum of 4 doses within 24 hours. And this actually you can sort of demonstrate, and this is just something that in pharmacology you can demonstrate with any drug really, that this will give you the sort of maximal effective dose of this drug. And it's something that we sometimes talk about with our patients who maybe have taken they've tried paracetamol, so they've got an ache or a pain, and they take 2 paracetamol and they think, well, I didn't do very much. And so their immediate thing is to then go up to a stronger drug. And one of the things that we try to advocate with the patients is to take their drugs regularly, because if you take your medication regularly, you're taking paracetamol as an example, if you take it at regular dose intervals for several days, then the actual circulating within the blood reaches steady state. So you actually get a significantly higher therapeutic benefit from these medications, therapeutic effect, when you're taking these medications regularly than if you just take a one-off dose, because you get this sort of cumulative effect within the blood, which is perfectly safe because your body's metabolizing it and excreting it at the appropriate rate, but it's something that oftentimes people don't try a medication long enough to exhaust this as a possibility. So it's something that we, oftentimes when we're trying to de-prescribe or to reduce the number of analgesics someone is taking, we kind of oftentimes try to sort of take them back to each of the medications and look at where it fell down, and did they give up on some of these other medications too quickly and too easily. So the classic will be, I tried a paracetamol, it didn't work, and you say, well, so what exactly happened? And they're like, well, I took it, I didn't really seem to have that much effect, so then I went and got some codeine. How did you get on with that? Well, I took that, it still didn't really seem to do it. How many times did you take it? Well, just once. It sort of made me feel a bit sick, didn't seem to work, so I went and saw my GP. What did your GP do? Well, I told him my paracetamol and codeine wasn't working, so the GP prescribed me Tramadol. So then before you know it, you've got patients very quickly escalating up the medications ladder. And one of the points that I sort of often make on, to people when we're talking about this sort of medicines management and about sort of trying to utilise medications to best effect. If every patient that came in to see you and you said, oh, how did you get on with your exercise? And they're like, oh no, it's not working. And you could just sit and go, okay, go to Orthopaedic, you're going to have surgery. If the exercises didn't work, you're going to have to go and have surgery. Or do you say to your patient, well, can you show me how you did the exercises? How many times have you actually done them? Are you doing them properly? Have you given them enough time to work? So it's about interrogating, around the things that the person's already been given to try versus giving up on things sometimes too easily and moving on to other more invasive or higher risk forms of treatment. So that's something that I really encourage people to potentially get involved in. And as I say, again, it's another little sort of quick win that we can have with our patients, because it's amazing how many times with a hop, skip and a jump these people get up onto the much higher end medications without ever really seeing what some of the other medications could potentially do for them.
Unlike some of the things that we do in practice, people, Joe Public, perceive that they understand painkillers better than they do other things. They wouldn't make those assumptions on antibiotics or statins. They seem to just have what they think is an intuitive knowledge of what it's trying to do and therefore how they take it. So they take it in a haphazard way. Is my reading of the literature a misreading or a correct one, that consistency is key to this, in that if they find a dose that might work for them, but to take that regularly is far better than just sort of spiking the graph and being more reactive to it? Or am I being a little bit pedantic on that? Because some people do prefer to react to their symptoms and vary their medication use, if we're thinking in the usual analgesics that we're talking about.
Yeah, I mean, I guess it slightly depends on the context of what you would be talking about, but yeah, but by and large, then for a lot of the people, then it's a lack of consistency is what is kind of really sort of blurring things for the patient. And one of the things that I'm really sort of like very sort of keen on when I'm reviewing people's medications and we're trying to sort of optimise people's medications is about sort of like trying to manage and control our variables. So first of all, kicking out any medications that I don't think are being useful or are potentially risky. We see a lot of people coming through and they're taking combinations of medications that they shouldn't be taking and stuff. So there's that, but then also consistency to see what the medications can actually do for them. There's several different factors here. There's the thing that we just talked about with the paracetamol, and you can say the same thing for most of the non-steroidals as well, which have also very short half-lives, and codeine has a short half-life. So all the over-the-counter medications really have these short half-lives, and they're all subject to the fact that you will get a short blip of analgesic sort of treatment effect from them, and then you have this sort of exponential slow tail off of the drug being excreted from the body, which, as we say, we can utilise that effect and the way in which the body processes drugs by taking them at regular dose intervals. It's certainly something that, in terms of, as you say, can you get more effectiveness and is it better to take them consistently? Almost invariably, yes. I guess my caveat on this is when we're putting together people programs, and now I'm thinking more in terms of more chronic pain management, I guess, where we would get people to, usually try to give us, so either some sort of graphical or drawn representation of what their sort of pain cycle looks like. Is there a consistent background level of pain, or do they get regular spikes, regular cyclical waves? And then you're always trying to design an analgesic program which somehow sort of mirrors what they're experiencing. Spikes in pain is always the most difficult thing to manage, because to get strong painkillers in effectively and quickly can be quite difficult, but there are ways of doing it, and there's ways of of achieving that to an extent. I think what we see a lot, the absolute sort of like things that we hear all the time in the pain clinic is I take my amitriptyline only when my pain's at its worst, for example, which is amitriptyline needs to be taken regularly, usually for most people for 3 or 4 weeks before we get a treatment effect. So taking amitriptyline, PRN or as required, is completely flies in the face of how amitriptyline actually works. And the same with Pregabalin. But again, we see this all the time, and hear about this all the time. And then what people say is, it makes me feel really sick, because oftentimes with a lot of these medications, we have this initial sort of nauseous effect from the medication, which tends to sort of settle down a little bit over time. So if they sort of stay with the medication and take them regularly, oftentimes that initial nausea will start to settle, and they can begin to tolerate the medication in many cases. So taking them sporadically, again, oftentimes goes hand in hand with patients reporting that they give them severe side effects, particularly if you're talking about drugs such as Tramadol. So people just understanding how they work and the nature of medications can really help people to understand what's going on.
Yeah, so one of the things is, you've just eaten up like some of my best questions, so you've saved me a job there, and we'll come back to some of the clarifications over those like side effects and the like. But just to map what we talked about there, which kind of goes across the board.
Yeah.
What about codeine and Tramadol then?
Yeah.
How do they act in difference to paracetamol? And then how might we mitigate? Because unlike paracetamol, you do then encounter some more systemic side effects that people get frustrated by. So.
Okay, well let's talk about codeine and Tramadol, because this has got a lot of potential points of interest, I think, from a clinical perspective. So first of all, in terms of how they work, so codeine is virtually benign as an analgesic in the structure that we actually take orally. So codeine itself has almost no analgesic quality, but it is metabolized in our liver, and the post-metabolized state of codeine is a substance which essentially becomes an opioid, a strong opioid. It's transformed into something that is very similar to morphine. So your body converts codeine into morphine for all intensive purposes. And if it doesn't do that, and again, this is why some sort of basic understanding of how your body processes drugs is so important, because when the substance that you actually take orally, if you're taking tablets orally, the substance you take orally is not the substance that goes into your bloodstream. It goes through the liver and is metabolized in the liver, and the liver changes the substance before it goes into the bloodstream. And many drugs, particularly analgesics, actually rely upon your liver to metabolize them, and to change the molecular structure of them in order to actually release, if you like, the analgesic effect of that substance. So codeine, if you do not metabolize codeine, has virtually no analgesic effect. Tramadol, if you don't metabolize Tramadol, has about 1/7 of the analgesic effect. And around about 10 to 15% of the population are unable, they don't have or they have mutations within the enzyme group, which is designed or is there to, is able to metabolize both of these drugs. About 10 to 15% of the population do not have the appropriate enzymes, or they have mutations in enzymes such that they don't become metabolized, and therefore codeine will be completely useless as an analgesic drug in 10 to 15% of your patients. So in other words, if you're seeing 15 patients a day, probably at least maybe 1 or 2 patients you see every day. And similarly with Tramadol, are, for all intents and purposes, immune to the effects of these drugs. So that, again, is just something to be aware of. A smaller percentage of people, so around about 5% of people, are what we call hyper-metabolizers. So they will metabolize these drugs very, very aggressively and will have a much greater exposure, if you like, to the therapeutic effects of these drugs. Unfortunately, it doesn't usually give them much more analgesic effect, but it oftentimes gives people much greater side effects because their body metabolizes it very, very rapidly. So you'll hear from time to time patients saying that they took, say, Tylex, which is, a strong, or the strongest end version of codeine, or 30/500, so 30 mils of codeine with 500 mils of paracetamol, and will feel very, very unwell oftentimes after taking this if they are hyper-metabolized.
Because they've just got a big shot of morphine all of a sudden.
Yeah, exactly.
As well as them feeling sort of sick. And then what about the more chronic side effect of constipation that's often been... Is that something that can be mitigated?
To an extent. I mean, with codeine, with Tramadol, certainly older people or people that are less mobile can sometimes, feel uncomfortable due to the effects that it has from a sort of constipation perspective. We usually, before suggesting taking these medications, just give people a little bit of advice about making sure that they keep well hydrated, try to move around regularly, make sure that they're eating, a good, lots of fresh vegetables within their diet. Prune juice seems to work very well for a lot of people. So try to offset from a sort of, if you like, a conservative way, and to try to reduce the effects of constipation. Obviously, sometimes people will, need probably more when you're talking about the strong opioids. They will actually need other medication to offset this. But as a principle, we try not to prescribe one drug to mitigate against the side effects of another. So try to avoid that. So usually try to advise people about sort of conservative ways of
dietary and lifestyle management. Head first off.
Yeah.
I've got a tale. Tell you, you'll be amused at this. A friend of mine, when we were band 5's physio, got a bout of sciatic pain, was taking codeine, was off work for a week or so, then was due back in on the Monday, and came in, and he wasn't there. He was on the medical wards. He'd had such bad constipation. It settled his symptoms, but he had such bad constipation. He's then straining to open his bowels, had a hernia, and then was admitted for a hernia repair in the medical ward in which we worked in that morning. So he had a gaggle of physios there, like at his bedside before he went down for surgery, laughing at him for straining into a hernia. So just a great codeine story, and he learned his lesson from there.
Yeah.
What about then with indications then? Is there a way in which, with paracetamol, cocodamol, Tramadol, Are there certain conditions or certain presentations or certain ages of patient or any of those variables, say the time frame of symptoms even, in which we should really be looking at one rather than the other, or should they be seen under a category in which it's more to do with intensity and personal preference?
Okay, so I guess one of the things that you would say with paracetamol, cocodamol, and I guess to an extent non-steroidals, they're over-the-counter medication, or certainly low-dose cocodamol with over-the-counter medication, paracetamol and non-steroidals. They're very good at tackling pain sort of quickly, if you like. So this is your sort of classic A&E triangle of drugs is paracetamol, codeine and a non-steroidal. And there is certainly good evidence to support the fact that these drugs are effective in mild to moderate pain in a good percentage of the population. So when we're talking about drugs, then we talk about NNTs, or numbers needed to treat, and you're looking at, with non-steroidals, they will be effective in acute pain in NNTs at around about 2 to 2.5 to reduce pain by 50%. So in other words, every other person or every third person would experience 50% pain relief with non-steroidals, mild to moderate pain if taken, relatively sort of quickly after onset. Paracetamol can have a role, as we've talked about, as a sort of co-drug, both in the short term and in the long term. So, it can be used to spruce up the effects of just about any medication, and we will see it being within a sort of medicines program for lots of our sort of chronic pain patients. Tramadol doesn't do very well oftentimes if you look at studies in the acute setting. So NNTs for Tramadol for acute pain is actually not very good at all, usually around about 1 in 4 to 1 in 5 for 50% pain reduction. So Tramadol doesn't fare very well as a standalone drug for acute pain. So I guess by the time you're looking at towards the stronger medication is when you're recognising that somebody might need to be on medication for a longer period of time. So obviously you're here on thinking about a patient that you think may have disc prolapse or something of that nature, or orthopaedic trauma, where they're going to have pain for a good while, and you would be looking to put them on a regime of medication that is going to manage their pain for sort of weeks and months rather than within a very sort of acute sort of context.
How does codeine fit in between that then in terms of NNT and time frames?
So codeine for NNTs for acute pain is usually slightly under non-steroidal, so you're looking at something like 1 in 3, usually most studies for cocodamol NNTs for reducing pain by around 50%. So it's not quite as good as non-steroidals, but as I say, usually if people are able to have all of these drugs, they don't have any contraindications and are able to tolerate all these drugs, it's usually, oftentimes it's given as a combination of sort of 3 medications in the acute setting, and that seems to work very well for a lot of people. Codeine can have a role in more sort of like ongoing subacute and chronic pain management. Although opioids generally, if you're going really then into sort of chronic pain, really don't sort of fare so well, and you'll be aware that there's been a massive increase, exponential increase, particularly in strong opioids, has actually gone up tenfold in the UK in the last sort of 10-15 years in the management of non-cancer pain. There's been a huge rise in the use of strong opioids generally in non-cancer pain, and this really flies against what the evidence tells us, which is in actual fact strong opioids do not seem to perform very well at all in chronic pain, and this is believed to be because the pathways on which opioids can perform, so the descending inhibition of the opioid effect seems to become exhausted, and therefore further opioid medication doesn't seem to give any effect. Or certainly that's one of the sort of schools of thought, if you like, as to why strong opioids do not fare very well in chronic pain.
Okay, and so I think the way that we've just done that with analgesia means that we've covered so much ground that we don't need to retrace. So if we can then rattle through, which is good, because I think that's been better. In my head, I thought we were going to go through sort of tablet by tablet almost, and then talk about a lot of the variables around sort of side effects, etc. But instead, what we've done is cover that, and then if we can then go to NSAIDs, touch on what they do, but then also touch on their usage, and we can go to tricyclics, neuropathics, fairly nicely from that, and talk about some of the clinical application from there.
I was just going to say, well, you can edit this in, because Tramadol we didn't really sort of cover in terms of mechanism of action.
No, sorry.
So just very, very quickly, because Tramadol, oftentimes people think Tramadol is an opioid because it has a predominantly opioid effect, but Tramadol actually was originally an antipsychotic drug, which was Trazodone, which wasn't very effective, but as you know, again, something to understand about medicines and medicines management and the world of pharmacology and the pharma industries, is the fact that so much money, so much investment goes into these drugs that they will always be looked at for any possible potential therapeutic effect that they might have, and if they can't find anything, they'll tinker around with it in the labs until they do. So Tramadol started life, or a pre-metabolized form of Tramadol started life as an antipsychotic. It wasn't doing very well, so it was then metabolized, and one of the active metabolites of it became a tricyclic antidepressant, which again wasn't doing particularly well, wasn't performing particularly well, and they tinkered around with it some more, and then we got Tramadol, which is essentially a metabolite of the tricyclic antidepressant which went before it. But the reason why I mention that is because Tramadol, whilst it binds to, once it's metabolized within the liver, it binds to opioid receptors, but equally it still does retain to an extent an effect on reducing the postsynaptic uptake of adrenaline and serotonin. So you wouldn't give it purely for that reason, because it's only a sort of slight sort of byproduct of what it does, but it does continue to do that, and that's important. Probably slightly less to do with its therapeutics and more to do with its potential side effect profile, and also in terms of implications when taking it alongside other medications such as tricyclic antidepressants, which is why a lot of GPs don't like to prescribe Tramadol alongside amitriptyline, for example, because they're both going to increase the levels of noradrenaline and serotonin, and then you're pushing towards things like serotonin syndrome and so forth, and also has been shown to sometimes cause fitting. So it's just about knowing a little bit about the background of these drugs and where they come from can be really quite useful when you're thinking about them and thinking about and advising about these medications.
Yeah, because the similarities we can talk about, but then the intimate differences are also relevant for those reasons. So that's great. These are central actors. Yeah. Whereas NSAIDs, they have a slightly different role in terms of their mechanism. So if we talk about, this is where I might have a faux pas, but generally speaking, although they have some differences, ibuprofen, diclofenac and naproxen, which are considered, are they COX-1? Do they count as?
So I mean, they are they are the non-COX-2 selective. So they inhibit the cyclic oxidase enzyme 1 more than COX-2. So the sort of story behind this is that obviously one of the biggest sort of biggest concern side effects with non-steroidals is that by the inhibition of COX-1, the prostaglandins that are involved in the production of the protective mucus within the stomach is stopped from being from working, and therefore people are laid open to potentially gastric trauma. and gastric bleeds. And so in an attempt to negate this issue, obviously the thought was, well, it's COX-1 does lots of quite useful little jobs around the body, so we don't really want to switch down COX-1. It's COX-2 that we want to inhibit, because it's COX-2, cyclooxygenase enzyme 2, which is involved in a sort of cascade effect, which ultimately is involved in the sort of inflammatory response. So they developed, the COX-2 selective non-steroidals, and I'm sure most people will know the sort of story with this is that they developed ever increasingly COX-2 selective until you got up to drugs such as Refacoxib, which is 1 to 1,000 more focused upon the inhibition of COX-2 versus COX-1. Unfortunately, the issue with this is that what they found was there was a very significant upturn in a number of cardiovascular incidents, heart attacks and strokes, and here we're referring to the Vioxx trials. So for a long time, COX-2 selective drugs were put on this naughty step, and no one wanted to go near COX-2 selectives for a while, quite rightly at the time. But obviously COX-2 selectives do have a role where your risk is that of gastric trauma rather than heart attack and stroke. So a young person who is responding very well to non-steroidals and may need to take non-steroidals for a prolonged period of time, their risk, provided they have no sort of heart problems, their risk is going to be that of gastric trauma. So for them, a COX-2 selective is probably the right non-steroidal for them to be on. An older person who is going to be potentially at risk of cardiac problems, or if someone with a history of cardiac problems, shouldn't be on a COX-2 selective and would be more appropriately managed on a on mainstream non-steroidal or COX-1 steroid, or however you wish to refer to it. And then we get to this whole story. Then we'd be aware that go back a few years, there was a couple of systematic reviews that were looking at the incidence of heart attack and stroke in people taking high or above higher doses, if you like, of the mainstream non-steroidals, ibuprofen, diclofenac and naproxen, and diclofenac was seen to be associated with the highest incidence of heart attack and stroke. This all kind of came about around about sort of 2005, 2006, the real sort of seminal studies involved in this. And for years then after, GPs have been advised, recommended, and eventually sort of financially incentivized and or penalized if they continue to prescribe diclofenac, such that I'm sure most people will be aware that the numbers of patients taking diclofenac has fallen by, I think it's around 75-80% now compared with 2006 levels, and far more patients are nowadays recommended naproxen because in the studies consistently naproxen has been shown to be associated with very little increased risk of heart attack and stroke in these patients, and certainly anyone who's had a heart attack or a stroke certainly shouldn't, any myocardial or cardiovascular problem shouldn't be taking diclofenac, or certainly avoiding non-steroidals as much as possible.
In terms of its action then, with say, let's just go with naproxen for now. There's some central acting, but there's also then it has an anti-inflammatory effect. What mechanism does it do that? Because sometimes patients and therapists will associate it as being just a local actor on the inflamed tissue, as if it's got some sort of homing device. But it's not quite like that, is it? It's more endocrine.
Yeah, so it gets into the bloodstream, obviously, and it's sort of like, it's circulating around the body, but at the area where there has been a trauma, obviously your body is trying to activate the inflammatory response, and the non-steroidal comes along, and through its effect on the COX-2 enzyme and therefore the effect on the local prostaglandins, essentially disrupts and attenuates the inflammatory effect, which gives us a relief, or gives us a relative relief of pain, But this is the other issue that oftentimes we talk about, in particularly obviously in musculoskeletal, is that unfortunately you cannot separate reducing inflammatory response from having a negative effect on healing response. So this is why non-steroidals have consistently been shown to have sort of negative effects on healing of bone, tendon, muscle. So again, it's for some people in certain patient populations, this effect may not be significant. So it's not to say that that wherever there's trauma, that people shouldn't take non-steroidals. But certainly, a lot of surgeons now, certainly if it's bone grafting or anything of that nature, they will try to avoid non-steroidals post-surgically. Certainly, if you've someone who is potentially looking to return to sport, then we would certainly not recommend people taking non-steroidals, particularly in the first sort of 24 to 48 hours, so that you don't disrupt that initial sort of reaction within the body, which is really essential for good healing. And non-steroidals, even in studies, all the studies really, even looking at sort of like muscle tears, and even muscle sprains and strains, whatever they are, have been shown to have negative effects on overall outcome where non-steroidals are used as part of the treatment and management package. So again, they're not a friend of healing, and they're not a friend of soft tissue sort of returning to normal, really.
And there's a fashion even for prophylactic use in certain sports and endurance sports, which is a nonsense from what I understand. I mean, that is not only, like, people thought at worst it did nothing, but actually it's far worse than that.
Yeah, certainly, there is unfortunately a huge trend, and we hear about it all the time, in gyms, through sports academies, and we did a sort of a marathon event evening, and one of the people who was training for the marathon sort of put his hand up halfway through the evening and said, are we going to be talking about when's the best time to start our non-steroidals ready for the marathon tonight? Because it's just got into the public psyche that that all part of the process is that you take the prophylactic non-steroidals will help to reduce your risk of injury. People become quite psychologically dependent upon. I treat a lot of dancers and performing artists, and a lot of them are very sort of psychologically dependent on non-steroidals, so they're really sort of worried that they will either become injured or they will have pain if they try to train or perform without non-steroidals. And the fact is, and there's been some good studies actually looking into this. The fact is that it's been shown that in actual fact your risk of injury is increased. And the reason why they think this is because your body's natural sort of healing of micro-trauma is being inhibited. They've also demonstrated a reduction in the normal sort of exercise response within tissues when we're training, so that your body basically isn't toughening up.
Not remodelling effectively because it's been inhibited. Yeah,
so in actual fact, far from protecting yourself from injury, you are actually laying yourself open and actually increasing the likelihood of injury. The other thing, particularly with sort of marathon runners and sort of extreme sports people that we see obviously a lot of nowadays, and that is the effects that it can have obviously on, for example, the kidney. The other thing that COX-2 does within the body, as well as being involved in sort of inflammatory response and early healing response, is it also controls the perfusion in the kidney. So where people take non-steroidals, say for example before a marathon or before some other sort of like endurance event, is that they've demonstrated when they've done blood tests afterwards that patients show signs of endotoxemia and mild kidney impairment from doing this. So you sort of think you're about to run 26 miles on a hot day. What you don't want to do is give your kidney a hard time. Yeah. So they really are, and I quite oftentimes actually given this out to many patients. It was an excellent paper written by Stuart Warden from the British Journal of Sports Medicine called Prophylactic Use of Non-Steroidals by Athletes, a Risk and Benefit Assessment. And in this paper, it really sets out all the myths, what people think it will do and what the studies and what's been shown to actually be the case. And I've given that out to a lot of my sort of marathon runners and extreme sort of sports people over the years, because we see this as a real growing thing, and use in gyms as well. We're seeing loads and loads of people using non-steroidals in gyms, and this
thinking it would help them train harder, won't it?
Yeah. And that asthma pumps, the whole lot, so this idea now of getting hold of medications as a way of sort of enhancing performance is, again, unfortunately, a sort of growing trend now.
Growing trend in even the most basic of amateur sports. That's what's interesting, isn't it? Now, I wanted to just talk about the therapeutic dose sort of question over NSAIDs, and the same questions as we did with analgesia as to the PRN versus consistency use, and how that might vary from your analgesias.
Yeah. So again, with non-steroidals, because of the nature of the way they're processed within the body, and because apart from the COX-2 selectives and naproxen have slightly longer half-lives, ibuprofen, diclofenac, if you still see it around, have got the very short half-lives. A lot of patients will get ibuprofen because obviously it's available over the counter. This ibuprofen certainly benefits from regular, consistent usage in exactly the same way that we describe for paracetamol and codeine. So this idea that it goes into the body and then is exponentially, so it's very, very slowly excreted out from the body, such that if you take it at the regular 4 to 6 hourly intervals, you get an increased, safe but increased level circulating within the bloodstream, which theoretically at least gives you an increased therapeutic effect, therapeutic benefit.
Is there anything to the notion that it has even on first use it has an immediate analgesic effect, but the actual anti-inflammatory effects are more from consistent use and have a delay, or are those differences being passed out falsely?
I think the evidence on if we're talking about, for example, sort of swelling within the soft tissue, for example, or anti-inflammatory effect, I think the direct benefit from non-steroidal usage is actually probably a lot more mild than people oftentimes sort of imagine it to be. So again, I would say that your sort of physical management modalities, i.e. compression, elevation, are consistently shown to be much more avert than the use of analgesics. So whilst it will have a dampening down of through the prostaglandin inhibition, a dampening down of your body's sort of inflammatory response, in terms of how avert that will be in reducing swelling, I think it's probably a lot more mild than people imagine it to be.
I think just looking at the time, what I think would be a good idea is, I only really want to put the main podcast out at like another 20 minutes or so, and I think the best use of your time for the mainstay of the listeners will be to then go on to some of the other questions around sort of the clinical frontline confrontations that we encounter, for want of a better term. And therefore I want to just skip the bit, although I hope if you've got time, me and you will talk a bit about tricyclics and neuropathic medication at the end, and I might just push that out to our patrons as an extra, or we might even put it as a bit of a bonus footage. But for the 20 minutes, I just think it would be optimal for us to talk a little bit about the excuses we encounter, the real, and then the stuff I'm sure you get asked a lot about on your courses, where this physio's pulling their hair out as to trying to engage people with it. So is that all right if we just skip to that bit? Yeah. So, with regards to, we've touched on it a little bit, I'm going to just bridge it seamlessly from the NSAIDs, is that one of the things that people I find anyway, people will be much more compliant with an NSAID than they would with an analgesia, because their perception of it being disease modifying, it helps them to get away from this idea that I don't want to mask the pain. So they'll buy into the idea in which it's actually altering their problem. Whereas if you were to, the mechanism that they perceive as being with paracetamol as just being a masking agent, which isn't in its, although the words I don't like, generally speaking, that they're not far wrong there, is we're trying to just make their body less sensitive, for want of a better term. So how do you encounter, do you agree that is the case? And with compliance generally, how might you counter that notion where patients just say, I want to know what my body's telling me, I don't want to mask the symptoms, I don't like taking painkillers for that particular reason?
I guess again, there are different ways that I would approach this depending on the context. So if I'm thinking about sort of it, I guess in a more sort of like acute setting, then I would sort of, talk to them about, reducing their pain in order to allow them to continue to be active, or in order to allow them to be able to move more normally. So I would try to sort of like sell it to them on from that, the benefits to them on that perspective. I'm always talking about, if it's with acute pain, there being a beginning, a middle, and an end to their analgesic usage. So it's the minimum dose required for the shortest possible time is always the mantra. And I think they will, if you're pushing it, if you're putting it to patients like that, they can see that your attitude towards medication is the lesser the better sort of thing. And I think from that perspective, then you can bring people on that side, sell them the benefits of the need to keep active and the need to keep functioning. So probably predominantly from that perspective. However, I always say, I'm not there, I'm there to facilitate informed decision making and patient choice. And if patients really believe that they don't want to take analgesics, then all analgesics have harm to them. And if they're making an informed decision, as long as it's an informed decision based upon bona fide and appropriate beliefs, then I believe that is their decision, and it's not against the law to not take medication when you've got pain. So they're allowed to do that. If I'm thinking more in terms of a sort of from a chronic perspective, I always, these are the things that I believe as a physio really open up the conversation. So oftentimes we will get the sort of classic, I don't want to mask over my pain because I'm worried that I'm going to injure myself, which then just takes you straight into this whole pain equals damage and the whole way of sort of thinking about it from that perspective. So I really see these as hooks.
Yeah, they open the door.
Yeah.
It's not a barrier as much as, and I used to see it as a barrier so much, and it was so difficult. Whereas now, you're right, it's an open door for that conversation. It invites that concept, doesn't it?
So I think it's really, it's really useful to be able to have those conversations and be able to bring out those beliefs. And for me, it just opens up that whole avenue of where you're going to potentially take them from a sort of chronic pain management and principles of chronic pain perspective. So I use that as an opportunity really when people are discussing from that perspective. If I guess if you're saying, if you really believe that person really it's in their best interest to take stronger medication because you really believe that they will be able to function at a better level, and it will allow them to, engage with therapy and engage with treatment more effectively, then, again, I will talk to them always about the risks and the potential net risk benefit, and talk to them about, trialling it for a set period of time, and we will set specific goals within that. And if they don't achieve those goals, and if we don't get the effect that we want, then it's about being open with the person and saying, if we don't achieve this, then obviously you can come back off that again. And being open about the fact that no one's got a crystal ball. I don't know. There's so many variables, as we know, in treatments, and pharmacology add another 500 variables to that about whether or not people actually will experience a treatment effect. Then I'm certainly not going to sell it to them like they are definitely going to get pain relief from these analgesics. It's all about having an open dialogue, open conversation, exploring these things together, bringing in their sort of thoughts, values, preferences, why they may not want to take them, and from that perspective, and that's how I sort of but you know, one of the biggest things that I think that prescribing and having these conversations has done for me is being able to open out these sort of conversations. And so many times I get patients booked in with me on the premise they want to discuss, they want to be on more painkillers, and you know, but actually what we end up doing is something completely different. And that you know, that is, to me, is why, you know, this sits so comfortably with what we as physiotherapists do.
Yeah, absolutely. Well, you don't have to convince me that more questions is a good thing.
Yeah.
You know, and that's it. We ask questions of ourselves, ask questions of our own knowledge, and then with those answers that we come up with, we can share them with patients if they want to engage with it. So that's great. I thought about what I think are the big three excuses made for poor compliance in my practice, and the first one was this notion of not wanting to mask pain, and we've covered that nicely. The second one is the side effects argument, which I think is a very much legitimate one. I think we've covered that in the most part with the chat we've had about. Usually it's the way in which they've used it, or their understanding of it, or their sometimes it's actually intimately tied to their compliance with the routine. Is there anything else you want to add in terms of side effects and how to either explain it to patients as well as to mitigate them?
Yeah, so sometimes it will be around, as we mentioned before, medicines, not so much misusage, but suboptimal usage. So they might be, for example, the person who's taking amitriptyline only when their pain's worse. So there's that sort of category, if you like. Sometimes it will be because you can spot some sort of interaction that the person hasn't spotted. And again, the classic here for me will be is when somebody comes off one medication, immediately goes on to another, and what they're not necessarily spotting is that the medications are clashing because they haven't given the time for one drug to sort of leave their system and before they take the other one. So the sort of classic will be when someone comes off, for example, high dose codeine, and then I went straight onto Tramadol, but it made me really constipated. I felt really nauseous or whatever, and it's like, when did you stop one and start the other? And I literally stopped one at sort of like 3 o'clock in the afternoon and started the other one at tea time, and you're like, well, it might be that you just got a little bit of a clash there.
Yeah.
You know, perhaps try again on a slightly reduced dose, and again, it's just about exhausting, interrogating around the specifics of how that event actually happened. So that would be another one.
And the bigger picture stuff you mentioned earlier with regards to looking at making sure you're thorough with the assessment in the lifestyle factors, dietary variables, exercise and pacing, the wider stuff would contribute to that consistency that we're looking for. And
managing people's expectations. So if we're setting people up on medication, then we spend a long time, I spend a long time going through with them the side effects that they're likely to experience, and really sort of set out to them that analgesic effects, side effects is a payoff, and it's a balance. And again, this really feeds into managing patients' expectations around what analgesics can actually expect to do. So, you know, even we're talking about, like, you know, the atypical painkillers in chronic pain. There's virtually no drug in a persistent pain or chronic pain condition that's really going to reduce someone's pain by more than 20, 30%, 40, 50 if you're very lucky, but I rarely mention those sort of figures. I'll say to patients, this may reduce your pain by 20, 30%. These are the side effects you're going to get. You have to weigh up these risks and benefits. So I'll talk about it from that perspective. And sometimes there are, and this is one that sort of springs to mind, a very recent one, just sort of like where you spot a side effect that the person wouldn't know of. So, for example, I had a patient came the other day. He was being managed really, really well on Pregabalin, and his GP had started him on Tramadol. And he said, I'm in quite a lot of pain, but I think it's because I had to stop the Pregabalin. So I said, did you stop the Pregabalin? And he just said, well, it's really sort of affecting my sort of like sexual function. Am I right talking about this?
Of course, yeah.
Yeah, all over 18, your listeners, yeah. So I said, like, so in what way is it affecting your sexual function? And he said, well, I can't climax. And I said, what, with Pregabalin? He said, yeah, I was fine to begin with. And he said, but I just found after a while that I couldn't climax. So that's really strange. I've never heard anyone say, are you sure? And he said, yeah, because I've stopped it and now I can climax again. I said, that's really strange. I've never heard of that before. I said, well, you know, it's interesting, an interesting point. And then he was about to leave, and he said, I wonder whether or not, he goes, it must have either been the Pregabalin, or, because the only other thought was it could have been the Tramadol. And I said, well, and he said, my GP started me on Tramadol. And he goes, thinking about it, it was around about that time that it started, and I stopped both of the drugs at the same time. The Tramadol, as I'm sure you know, Jack, is given for premature ejaculation. So
I know as well. Thanks for that.
So,
the listeners are going to be worried about why you know that I know. That's going to be the bigger question. Scandal.
So that was a sort of classic to me, like, one of those sort of things where I just said, right, so that's the problem. And he successfully went back on Pregabalin again. And who would have thought it? Who would have made that connection?
Absolutely, and it takes for that intimate knowledge of the medications to recognise the differences, because it would have been, and obviously a big deal to that guy's life, especially if he was benefiting from the Pregabalin, to then come off it would be massively disruptive. So, absolutely perfect story, as well as an entertaining one, of course. Side effects wise, that totally makes sense, and I love that what you were saying about the fact that we've got to present the patients with the ups and the downs, and that is the informed decision making, which I'm going to come to in a little minute. I mentioned three top excuses. The third one being, I don't want to get addicted. Now another one of those things, as with all of them, I think that part of the reason that these are difficult is because it is unhelpful if physiotherapists impulsively, on all three of these, don't want to mask it, side effects and addiction, if physios, as with any professional, is utterly dismissive of those things and weren't able to articulate them in a really coherent human-to-human interaction, I think that part of the danger is that would then be, if they're too dismissive, it wouldn't engage the patient. So on that third one, how would you go about, I'm sure you've heard that plenty of times, how do you go about then helping people to understand it and then improving their compliance off the back of those worries?
I mean, I guess there's a sort of context thing here. Sure. You will get sort of, some people just give a very sort of, frivolous, I don't want drugs, I don't want to get addicted to drugs sort of thing. And then it's about just the very sort of, I guess, fairly simplistic sort of advice around the fact that, the vast majority of medications do not have any, if you like, physiological sort of addiction, to them as such. Obviously, opioids may have both in terms of a psychological and a physiological addiction component to them. But if they're taken for the appropriate reasons in the presence of pain, and this is the sort of key thing here, that the numbers of patients, or the percentage of patients that get addicted, are generally quite low. So the British Pain Society has sort of estimated that true addiction to opioids that are taken in the presence of pain is probably something around like 2 or 3%. So it's relatively low, and obviously if we're talking about the drugs that have no sort of physiological addictive component to them, then it will be less still. I guess the conversation, the more sort of intricate conversation that sometimes we might have with our, if a chronic pain patient, or if it's been explored in a little bit more depth, is to talk about addiction very much as a behavioural thing. People can become addicted to anything. People are addicted to their phones, iPads, this, that and the other. But addiction... Podcasts. Yeah. Addiction is very much a sort of behavioural thing. And it's the classic that I will get, the classic thing that I sort of hear a lot or whatever is, I don't want to take an opioid because either I or my friend became addicted to opioids in the past. What are you doing? Suggesting an opioid to me? Are you trying to turn me into a drug dealer or something? That's the sort of classic sort of like conversation we have. And so, I will so I say, right, okay, so when you took opioids before, in what way did you become addicted to them? Oftentimes they'll say, oh, well, I was in hospital, or my GP prescribed opioids, and when I stopped taking them, I sort of felt sort of slightly clammy, and often embarrassed to tell me I felt slightly sort of clammy in my hands and felt a little bit shaky. And it's just explained to them that this is a normal physiological, almost like recalibration of the body, the cells within the body when we stop taking opioids. It's a perfectly normal physiological response. It's got absolutely nothing to do with the person being addicted. And an addiction is about someone seeking that substance again. So, you know, addiction would be then going around the back of the hospital and trying to score some morphine. If they're just feeling sort of clammy, that is a normal physiological withdrawal response. Addiction is a behavioural thing. Obviously, if you're working in A&E and working in a clinic where you are there and as work potentially to prescribe, we do obviously observe addiction and we observe addictive behaviour, and it is very much and we talk about this a lot on the course, and how to sort of spot addiction behaviour, and it's this, the key thing is this sort of seeking that people do. So they will sort of come in straight away saying, oh, can I just double check that I am actually going to get a prescription today? You can actually prescribe because I'm nearly out of diazepam or I'm nearly out of Tramadol. Can I take the prescription now just in case we forget? So they're kind of almost like obsessed with getting the prescription. And those are your sort of red flags, if you like, for addiction. Most people, if they're taking painkillers for pain, do not become addictive, except that some people do, and certainly higher doses taken for more prolonged periods of time correlate with addiction. So this is why it's so important that if people are going on to controlled drugs such as opioids, Tramadol, that they have their medications regularly reviewed. And also what I'm very sort of passionate about is not constantly increasing the dose of people's medications. I think this is something that is just got, it's become within the sort of psyche of clinicians, if you like, that at the end of sessions, for no apparent reason, they add a medication in or they up someone's medication just as a way of almost ending the consultation.
Or as an obligation for the feeling like there needs to be something new introduced.
Yeah. Or the patient, is having a flare-up. And so the patient comes in because they've had a flare-up, and there's this sort of like, immediate that the person must have, outgrown the level of drugs that they're on. So rather than trying to manage the flare-up and reassure the patient, and there's this immediate shortcut from thinking where suddenly all their drugs are put up or other drugs are added in. And again, I'm really, really hoping that, as a profession, we don't sort of like, start down that route, and that we are actually, very much involved in preventing that from happening. And we're looking at holistic management of long-term conditions, and and drugs have a role within that, but we're not seeing it as, because I've got a hammer, everything looks like a nail. I've just got to prescribe my way out of this situation.
Yeah, and I think that's, you've hit the nail on the head there with the habit thing. It's just like, we need to recognise as well, if we see these habits, both good and bad, in patients, we need to recognise them in ourselves too, or any of our colleagues, in which, if there's just a habit, as you said, a way of ending a conversation or a way of moving things out the door, that is unhelpful in those circumstances, when we really should be making sure we practice what we preach and make a plan that's more thorough.
And habits are hard to break, and we can only look to the prescribing patterns of antibiotics and the difficulty that it's taken, even though it's regularly sort of flagged up as being one of the biggest sort of risks to human civilization, is the sort of growing sort of immunity amongst to the available antibiotics. But even then, people still in their droves get prescribed antibiotics for things that do not require antibiotic use.
The patient's begging for them as well. It's difficult to turn that ship around in a sense, isn't it? One of the things that we end up in, this transcends loads of podcasts now, is the evidence, rightly, in many ways, is pointing towards this exhaustion of conservative management, this notion in which we've tried to engage someone in lifestyle changes, exercise therapy, loading-based interventions, alongside adjuncts such as medication, which we've talked about. And in doing so, what we're trying to do is trying to sell that package, and it does take time for that to really take hold to rehabilitate someone, as we know. Now, in doing so, we're trying to keep them from more interventional options, be it injections or surgical procedures, and sometimes even investigations in that direction. Now, with that, part of the difficulty we've talked about with compliance, but I want to talk to you about your personal perception over how persuasive physios should be to try and assist an appropriate time frame for that exhaustion of care before moving them on elsewhere. And so I speak to you as an ESP as well as a prescriber, do you think sometimes we are too dogmatic in trying to sell those things, or do you think that sometimes it's almost a relief in a sense that we get as arm turned and we then send off to our medical or surgical colleagues? What's your sort of take on that matter?
Yeah, I think, informed decision making, evidence-based medicine, this is, a topic that I think we all eventually sort of turn to and because I think it is so important to be aware of this and be aware of our own bias and be aware of how we can potentially influence how patients sort of make decisions. I really believe that our role is to put forward a balanced view of the evidence, and that and I believe that the evidence is very much in favour of conservative management and exhausting conservative management, and the invasive treatments, if we're talking about, for example, spinal injections, we're talking mainly sort of spinal conditions here, they may give a short period of relief for some people, and I think the more the further down the line and so forth they are, the sort of more attenuated that potential for effect will be. And equally with surgery, I'm very loath to ever sort of really recommend people down that route, because I really don't believe there's very much in the evidence at all to suggest that it's in people's best interests, save for very few potential situations. Equally, however, I'm aware of the fact that people have their own preferences, values, risk assessments, and aware that we don't all live our life like Mary Poppins, and that people will, are allowed to make informed decisions about what they wish to do with their life, and they've got their own reasons, much of which we may never be, privy to as to why they wish to make their decisions. So in terms of to what extent do I think we should sort of persuade them, I think I think that the weighting of the evidence probably is not too discongruent with my own sort of views, if you like, in terms of when and where it should be used. I think sometimes there's this, and again, I know some people would argue this isn't the case, but I think sometimes people just need to go and have that conversation with the surgeon, because I think sometimes you can almost exacerbate the belief from the patient that they are somehow having a particular form of treatment withheld from them. So provided the person that you are referring them on to, will also give a balanced view and will only operate if they feel it's within their best interest. And I think sometimes there is a role for that.
A well-worded letter can assist that process, and a good relationship with a local surgical team can sometimes help for the same message to be delivered from different angles to try and do that. And there's evidence to suggest certainly that hearing the similar messages from different sources is helpful for that penny to drop and to improve the buy-in if we are struggling, rather than the hitting head against a wall and trying to twist people's arm. Yeah,
and I think, I guess the usual things I'm sure everyone sort of talks about, and that is, exhaust conservative first, see where you get to, see where we can, optimise your conservative management through everything, exercise, chronic pain principles, activity management, the whole lot, plus or minus any sort of analgesic component, that may or may not be involved in that. See where you get to, and that's the point that you need to make your decision from. But the decision needs to be a realistic one. It's like the you estimate from there. You've probably got 50% chance of being very little better or worse. You've got a 25% chance of being, you know, slightly more better, and 25% chance of being very much worse. And you know, and I think the more chronic and further down the line you are, the more it sort of almost swings towards the pendulum leans towards the fact that they're more likely to get a less favourable outcome. But I think making a decision once they are confident they've optimised all other aspects of their care is the position that they should be making that decision from.
No, that sounds a completely reasonable position, and certainly not dissimilar to mine. But I would say that's easy to bandwagon because you've said it so well. Final question before we maybe go into extra time. How important is speed of prescription, and therefore how useful is it for MSK physios to have non-medical prescribing access?
Well, I would say, you know, if I sort of think back to the, if you like, the recent sort of past, I guess, I mean, speed of prescription, certainly in private practice, I've got a lot of people, I work in the City of London, lots of people cannot make it along to their GP or find it very, very difficult to get to their GP, and it's amazing what, I think something that I've learned over the last few years is just, you know, that what you think would be very straightforward and very easy, you say, well, just go back to your GP then, but people don't. So, you know, so actually saying to the patient, I can actually prescribe this for you now, I can do you a letter, you can take it down the road. That, you know, it's they're just amazed that you know, and very, very sort of positive about that being part of what you can do. So it would be anything from a very acute sort of like neck radiculopathy, or, you know, I can think of so many different contexts. I had a very sort of high-flying business lady who'd had a hip replacement, and she just could not get back in to see her GP. She was working ridiculous hours, or the surgeon, and she just wasn't sleeping. We weren't getting anywhere with her rehab, basically as much as anything else, because she just couldn't get any sleep, and we prescribed her some medications, got on top of her sleep, and it was a huge turning point in her overall rehab. Patients who had a lady who'd had neck surgery, and every single time she went back and said they would only prescribe her Pregabalin for like 3 weeks at a time, and kept on telling her that she had to come off it, even though there was absolutely no medical reason why she had to come off it. So I was told it was only for a few weeks after her surgery, and I liaised with her GP over the phone in that clinic. She said, every time I come off it, bang, my pain goes flying back up again. Again, very busy lady, couldn't get into a GP, phone call to the GP, have you got any reason why you feel this lady couldn't be taking Pregabalin long term? No, bang, prescription. And I just think that it just gives you that flexibility. But I think more to the point, if you like, where it really comes into play, and this just transcends everything that we've spoken about today, is about being able to have the conversation, the one-stop shop, building that trust and alliance with the patient, being able to incorporate it, integrate it in so many different ways with what we do on a day-to-day basis, you know, spotting unusual side effects versus using it as a way of opening up someone to about their beliefs versus using it as an adjunct to, you know, what you're doing. There are just so many different ways that the knowledge, rather than the actual physical act of writing a prescription, I use sort of day in, day out with my patients. You know, and I know a lot of physio prescribers, and you know, and I hear very sort of similar stories of, it's just, you know, once you're doing it, you just can't imagine how you ever did without it. And I think it's the knowledge and how that allows you to engage with your patient way more than the actual writing of the prescription itself. However, in order to get that knowledge safely, and I think to almost like to protect ourselves, then, you know, then I would still encourage people, you know, where possible, to you know, onto the non-medical prescribing program, because I think it is having that breadth of knowledge, even though you may only prescribe in a very specific area. I think the safest way to do it is to get that robust breadth of knowledge across all the drugs, because the way in which drugs interact with each other oftentimes have very little to do with therapeutics. You know, they're molecules within the body and they interact with our body, and that's how drug interactions occur. Oftentimes nothing at all to do with their sort of therapeutic group, and that's why I think having breadth of knowledge across all the medications is the way to go, and I think that's how people should ideally learn it. But I know that that's not open to everyone, and I accept that.
And I mean, the evidence is certainly emerging now that people like yourself are more about within the world of clinical practice, is that we are performing well in comparison to our medical colleagues, in a sense that we're not finding ourselves getting the new badge and then waving it around, and therefore patients end up taking more medication. Evidence to show that if anything, we're taking people from them or tidying up people's prescriptions. I understand that some of the interprofessional research regarding our impact has meant that not instead of the concern that we will be treading on toes, many GPs are very appreciative and surgeons appreciative of our input in these sorts of things. So that's all positive news so far. Just to wrap up then, Dave, where can people find more about you, and where would you like to point people in the direction of, as well as some of the stuff we've talked about today we will make available to our listeners through our show notes newsletter. But yeah, more about you could be found where?
Yeah, so I mean, I teach a sort of range of courses in terms of freelance. I do sort of short courses around advising patients about use of medication, medicines management. I also incorporate this oftentimes with talks about injectable substances, which is, because obviously as an injection therapist and someone who's sort of very into sort of ultrasound guided injections, so all these things sort of merge together. So I do a sort of range of various talks and courses around these sort of topic areas. You'll see some of my other sort of musings to do with the sort of overlap between medications and injections and ultrasound. On the ultrasound side, a couple of pieces about, for example, fluoroquinolone antibiotics with tendinopathy, and a few bits and pieces on there about various different injectable substances and sort of how they can be sort of most effectively used. And I teach a couple of different, various different MSc modules and courses, and work on as an external examiner a couple of universities as well on sort of medicines management and non-medical prescribing programs. So my sort of name pops up in various places. If people,
where can people best contact you? Is that through social media? Or?
Yeah, and I'm chair of ACPOM-IT, so I'm easily contactable through the ACPOM-IT website, which is the Chartered Society of Physio and Orthopaedic Medicine and Injection Therapy. So people can email me directly through there as well if they've got any questions or anything else that they would find sort of useful to talk about. We're little plug for ACPOM-IT, I guess, here, because we're just about to have our sort of main conference day, and our sort of year plan over the next year is that we are very much going to be concentrating on developing our online resources for members, which is going to include hopefully some very good examples of things such as PGDs, consent forms, patient information leaflets, which is obviously going to be very much linked around sort of injections, injectable substances, but we will probably also look to expand that as well, because it's an orthopaedic medicine as well as injection therapy, clinical interest group and professional network, so we'll look to include some stuff around some other medications as well, I think. Because I think people find that useful.
Yeah, and we're gonna tell you all, probably in the intro you might have heard some, and then the outro of this will give all the appropriate links to ACPOM-IT, who we're going to do some more work with to try and get their messages out there. I'm sure you'll have enjoyed this podcast, and we've got more to come from those guys, because they've got so much to share, as the clock is telling me. As I say, if Dave's got the time now, we're going to just touch on, as a bit of bonus content, so find it on Patreon if you want to hear more about tricyclics, so your amitriptylines, nortriptyline, and then your neuropathics, pregabalin, gabapentin. We're going to go into that as a bit of overtime. But for now, thank you very much, Dave. Really appreciate your time today,
Thank you.
and I'm sure we'll speak again.
Thank you.